So during my topic, I'm going to try to focus on some of the impact of how we set the ventilator on the occurrence of some of the asynchrony events, some of the main asynchrony events that we've shown you, that Laurent has shown you before. And I'm going to focus my talk on intubated patients. We can add a few comments on NIV during the discussion. Well, as Laurent showed you, in their study with Arnaud Thiel, they documented that approximately 25% of patients on pressure support, intubated patients, had an index of severe asynchrony, most of the asynchrony they documented being ineffective triggering. This is not so surprising if you look at some of the basics of physiology, and if we look at this very nice paper from Yamada, from which I've adapted this little cartoon here, I think it's pretty obvious and predictable that we are going to run into problems when we put together a ventilator which has a distinct pressurization profile in terms of slope, duration, and pressure, and the patient who has another type of inspiratory profile. And when we put these two together, it's fairly obvious that they're not going to be a perfect match. If we look at this cartoon representation of a simple interaction between patient and ventilator, and we put in the center of the slide the equation of motion of the respiratory system, if we look at this from the patient's point of view, we have a triggering effort, which is the muscular, pressure muscular component of this equation, which is going to trigger the ventilator, which in turn is going to pressurize, and this is the P airway component of this equation. And this is going to give a given amount of pressure and volume in the respiratory system, which is going to, through a complex series of feedback loops, influence the the respiratory center. And again, this will influence the patient's respiratory drive and muscle action, and we go into one of these loops that go on, and hopefully they should not be too badly asynchronized, but unfortunately, given what I've shown you on my preceding slide, it's to be expected that they are not going to be a perfect match. And what we're going to see now is how to minimize the damage here in terms of asynchrony. So if we look at this classic representation of a pressure support cycle, I'm going to focus the talk on pressure support, we can see that there are basically four phases to it: inspiratory trigger, pressurization slope, the level of pressure support, and cycling into expiration. Well, let's start with inspiratory trigger. The ventilators we have today, as shown very nicely by this recent study, all have very sensitive triggering systems, because if we look at this bench test, which was done by Laurent's team, you can see that almost all ventilators have a response time which is below 100 milliseconds. 100 milliseconds is important because above 100 milliseconds, we become conscious of our respiratory actions. And so in case of triggering the ventilator, it means the patient should, and we don't know the clinical impact of this, by the way, but should at least be conscious of the inspiratory lag time before the ventilator responds. So all ventilators today have or most of them at least, have very sensitive triggers, and this issue of triggering sensitivity should no longer be a big problem. However, as shown by Laurent, triggering asynchrony in the presence of intrinsic PEEP is clearly a problem. In this slide here, taken from the study Laurent showed before, you have the esophageal pressure here, the flow is this curve here, and the airway pressure, this one. And as you can see, the esophageal pressure curves shows you these orange arrows correspond to inspiratory efforts. And as you can see, these inspiratory efforts are not followed, as are the green arrow accompanying the other inspiratory efforts, are not accompanied by pressurization by the ventilator, meaning that these are ineffective efforts for the reasons that Laurent explained before. Now, this is assist control mode, but we could very well give the same demonstration in pressure support, and this is without the application of PEEP. Now, when PEEP was applied to counter-effect the inspiratory threshold effect of intrinsic PEEP, you can see here that the number of ineffective breaths clearly declined. meaning that if you are ventilating a patient at risk for intrinsic PEEP, most of the time that would be patients with COPD, and you witness ineffective efforts, you should look at whether increasing or applying PEEP, external PEEP, might offset this inspiratory threshold load of intrinsic PEEP and thereby decrease the number of ineffective breaths. This is not the sole action to take in the face of ineffective efforts, but this is at least one that should be taken into account if ventilating a severely obstructive patient. As we will see, there's another course of action which is looking at the level of pressure support, and I'll come to that in a little while. Now, the pressurization slope is a fairly straightforward issue, at least apparently. Several years ago, Guy Bonmarchand from Rouen and his team showed that as you decrease the time taken to reach the preset level, meaning you sharpen the pressurization slope, you are going to have a decrease in the work of breathing, and this was shown both in restrictive and in obstructive patients. So intuitively, that would mean that the easiest option is to put the fastest pressurization rate possible on the ventilator. However, it's not so simple. If you look at the data from Bonmarchand studies, you can see that in the range where we usually set the our inspiratory rise times, which is between 102 or 300 milliseconds, not more, there's no real difference. And what he showed was that if you make a very slow pressurization rise time, then you're going to increase the work of breathing. So a fast pressurization slope is good in the order of 100 to 200 milliseconds, but not too fast, because if pressurization is too fast, as shown in this study in intubated patients, there's a risk of severe discomfort. And you can see here the authors looked at both an index of respiratory muscle workload and here a dyspnea score, and they compared pressurization rates going from a slow pressurization rate to a very fast pressurization rate. And as you can see, this is consistent with Bonmarchand's finding. As you steepen the pressurization slope, you make it faster, then you decrease the work of breathing. But if you make it too fast, then you increase the work of breathing. Most of the time, this is going to be due to patient discomfort, which was present also in these patients, and the development of patient ventilator asynchrony, coughing, dyspnea, tachypnea, which can be seen in patients who tolerate poorly a very fast pressure rise in the airways. Now, if we look at the level of pressure support, there are several studies which show the results that I'm showing you here. As you increase the level of pressure support, which would be from this dark line here, which would be no pressure support, down to the dotted line where you have 15 centimeters of water pressure support, you have a decrease in the diaphragmatic electrical activity, and this is accompanied by a mechanical action, which is a decrease in the inspiratory diaphragmatic effort. So the more pressure support you apply to the patients, the less work the respiratory muscles are going to perform. So again, intuitively, one might say, if my patient's respiratory muscles are weak or fatigued, then I should set the highest level of pressure support possible. But there's another pitfall which awaits us if we do that, and this was nicely shown in terms of clinical consequence. Laurent showed you this slide before. The percentage of patients with ineffective triggering was much higher in those patients receiving the highest level of pressure support. And why is that? Well, it was shown almost 15 years ago in a study which showed comparable results, meaning that if you increase the level of pressure support, there is an increase in the level of ineffective efforts. And the authors of that study looked at the difference between those breaths that preceded non-triggering attempts and those that preceded triggered attempts. And as you can see here, the difference is that those non-triggering attempts were preceded by breaths with a shorter respiratory cycle duration, but a higher inspiratory over expiratory ratio, a higher tidal volume, and therefore a higher level of intrinsic PEEP, meaning that if you over-assist the patient, you're going to worsen dynamic hyperinflation, intrinsic PEEP, and therefore the inspiratory threshold load of that intrinsic PEEP. And if you increase the inspiratory threshold load, you're going to increase the number of ineffective efforts. Therefore, the solution is, in those cases, to decrease the level of pressure support. And this was shown also by a study by Laurent Brochard's group. They decreased the level of pressure support from 19 to 13 centimeters of water in a group of patients who exhibited marked ineffective efforts. And as you can see, they obtained a clear decrease in the number of inspiratory efforts. They also saw that the patient respiratory rate could now express itself, and this is in blue. You have the patient's respiratory rate, and this is the respiratory rate indicated by the ventilator. And since the ventilator does not see the ineffective efforts, when pressure support was decreased, there was an increase in those breaths that were recorded by the ventilator. The ventilator could see these breaths because now they were all triggering breaths. So this means that if you have a patient with ineffective inspiratory efforts, you should clearly look at intrinsic PEEP, application of external PEEP, but you should also look at whether you're over-assisting the patient and thereby worsening intrinsic PEEP through over-assistance. And a combination of decreasing the level of pressure support and applying external PEEP is probably the way to go to decrease the number of ineffective efforts. Now we come to the subject of cycling. Here's a little cartoon showing you a typical pressure support breath. This is the pressure, and this is the instantaneous flow. And in green here, I show you the neural inspiratory time of the patient. This is another representation of what has already been shown to you before. If you have an obstructive patient, the flow profile is going to be more spread out, and the usual triggering level, which is 0.25 of peak inspiratory flow, is going to be reached later in an obstructive patient than in a normal patient. And this is going to result in pressurization by the ventilator in excess of the duration of the neural inspiratory time. And this is what we call delayed cycling. And so this problem in obstructive patient is going to result in activation of expiratory muscle discomfort and is another clear example of asynchrony. So what can we do about it? Well, if we can change the triggering, the expiratory trigger from, say, 0.25 to, let's say, 0.6 in this example, then the ventilator will trigger sooner into inspiration, will cycle sooner, and in my example here, of course, this is a cartoon, it perfectly matches again the neural inspiratory time. Now, of course, in the clinical setting, it's not as easy to do, but the concept is here, in obstructive patients, one should increase the level of triggering, of expiratory triggering, to better match the mechanics and the neural inspiratory time of the patient. Sorry, wrong. Okay, and in a study we performed a few years ago, we could show that as we increased the level of triggering, expiratory trigger from 0.25 to 0.5, we could actually decrease the inspiratory excess time, decrease the magnitude of patient effort, and this was accompanied by a decrease in intrinsic PEEP and a decrease in the number of non-triggering breaths. So actually, when one witnesses delayed cycling, and this is usually clinically manifest when you see a patient contracting abdominal muscles while the ventilator is still in its pressurization phase, then you should try to manipulate the expiratory trigger by raising the level and seeing if that at least solves part of the problem. So can we go a step further? Well, possibly through some automatic algorithms. Now, this one was documented quite some time ago now by Laurent Brochard's group again. It's now commercially available, and it's mostly used for weaning, but I just want to show you the part where it automatically adapts pressure support. And the core of the system is that it automatically adapts pressure support to maintain the patient, in what is known as a comfort zone, which is based on respiratory rate, tidal volume, and end-tidal CO2. And in this study, which was performed in a small group of patients, spending 24 hours on the automatic mode and on the clinician set mode, the authors documented that the patients on automatic pressure support spent much less time during those 24 hours in a pattern of ventilation which was outside the comfort zone, and also that their respiratory drive was much lower than that of patients in whom the clinician set the level of pressure support. And this was performed with comparable levels of pressure support. It was not a question of this system, automatic system, giving more pressure support to the patient. It was just a matter of more frequent adaptation to the patient's respiratory profile. So this might be an option to better tailor the level of pressure support to the patient's respiratory pattern. And of course, it's been shown already, neurally activated ventilatory assist, due to the fact that it detects diaphragmatic EMG activity much more proximately, therefore, than all our pressure and flow sensors, can decrease the trigger delay, as shown in this example from the initial study by Chris Sinderby. You can see here that the trigger delay in pressure support disappeared when neural trigger was applied, which is fairly to be expected, given that it detects the diaphragmatic activity almost instantaneously. And of course, some studies are now coming out showing the clinical applications. This is one from our group, showing that in a group of intubated patients, compared to pressure support, there was a decrease with NAVA, disappearance of ineffective efforts, late cycling, premature cycling, and overall asynchronies using NAVA. And there are other data out there that show the same thing. So again, this might be one of the options in the years to come. To conclude now, ventilator settings, I think, can clearly impact patient ventilator asynchrony. A systematic analysis of the various parameters and determinants is needed because we're not still quite sure which asynchronies are bad for patients in terms of outcome and which are just there, as we discussed this morning with Laurent after the talk on NIV. Setting adjustments can clearly reduce asynchrony, and for now we mostly have manual adjustments and based on our clinical judgment. And of course, automatic adjustment algorithms, such as the one available known as SmartCare or NAVA, can reduce asynchrony, but we still don't know exactly what they can bring us in terms of patient outcome on a day-to-day basis. But so far, they are very interesting research tools. So with that, I'll conclude, and we'll take any questions you might have. Thank you very much.